So good evening everybody. Hope I am audible. If you have any doubts, please post in the chat section and we will begin with today's lecture. So yesterday we stopped at brain injury. We saw different types of bleeding inside the brain and how to manage them. So today we are going to talk about how do you maintain a good intracranial pressure. So we saw that when you want to maintain a good cerebral perfusion pressure, which is called as a CPP, cerebral perfusion pressure, you need to actually do MAP minus ICP. So what is MAP, what is ICP? So the mean arterial pressure minus the intracranial pressure is going to be your cerebral perfusion pressure. So what do they say is that the cerebral perfusion pressure should be more than 60 millimeters of mercury. Then only the brain is going to survive. We saw that whenever the bleeding is going to set in, that is going to be the primary head injury, and whenever the edema is going to accompany along with that, whenever the hematoma is going to expand, there is going to be formation of secondary brain injury. So to prevent the secondary brain injury from forming, we have to maintain cerebral perfusion pressure more than 60. Another thing is we have to keep the patient head up. So what is going to happen if you are going to put 30-degree head up? The venous return from the head is going to increase, and because of that increased venous pressure, the increased venous return, the head injury, the intracranial pressure is going to be low. So the venous volume which we saw in the Monro-Kelly doctrine, so this venous volume is going to be added when you are going to put the patient in the proper position. Then sodium, as I said, keep it slightly on the higher side, more than 140. So normal range is still 150. So keep it above 140 and try to use hypertonic saline to reduce the cerebral edema. So there is another controversial question which might come: when to prefer 3% NS versus Mannitol. So Mannitol is going to be always going to be a safe choice, because 3% NS you will have to monitor electrolytes daily. So, but what is the problem with Mannitol? When the patient is going to be hypotensive, Mannitol is going to cause more hypotension and worsen cerebral perfusion pressure. So whenever a patient is having hemorrhagic shock, whenever the patient is in shock, prefer 3% NS. But whenever the patient is going to be normotensive, the patient's only component is going to be head injury, then you are going to prefer Mannitol. So when to prefer Mannitol, when to prefer 3% NS, we have to know. Oxygenation, as we said, keep the SpO2 high, always above 95. If the patient is not maintaining on the oxygen mask, we intubate the patient. We also saw that the criteria of intubation is GCS less than 8. So you are going to intubate the patient. Osmotic therapy, whenever we know that the brain is swollen, we will give osmotic therapy of Mannitol, but always make sure that the osmolarity should not go below 320, because if the osmolarity is going to go below 320, naturally it is going to worsen the edema. Hyperventilation. What happens when hyperventilation is going to take place? The CO2 is going to be washed out. So when the CO2 is going to reduce, whenever the CO2 is going to be reduced, you know that CO2 can directly diffuse from the blood-brain barrier. It is going to cause vasoconstriction. Whenever the CO2 is more, there is going to be formation of more lactic acid, because we know that CO2, because of the Henderson-Hasselbalch equation, more CO2 is going to translate into more H+ ions. So whenever the CO2 is going to reduce, the acidity is going to reduce, and hence the vasoconstriction is going to take place. But mind you, if you are going to use it, make sure that you use it only as a transient measure. If you are going to actually do it for a large or more number of time, the patient might have secondary brain injury because of reflux cerebral vasoconstriction. Temperature, try to maintain normothermia. If the cerebral patient worsens, you can even make the patient hypothermic. And for seizure prophylaxis, you are going to give levetiracetam. So these are the non-intervention things which you are going to do to maintain ICP. What are the interventional things you can do? So what are the interventional things? So first thing which you can do is put EVD, external ventricular drain. So that external ventricular drain is going to drain the CSF and again going to reduce the intracranial pressure. Second thing is VP shunting. So whenever you are going to do a shunting, it is going to reduce, the CSF is going to go from the brain to the peritoneum or the pleural or even the pericardial cavity, and that is going to reduce the cerebral perfusion pressure. And third important thing is what in trauma we prefer always doing. It is always and always going to be, yes, it is going to be decompressive craniotomy. So in trauma, the first thing which you can do is a decompressive craniotomy, because it is going to suddenly reduce the intracranial tension and the brain is going to swell. But whenever you are going to talk about tumors, whenever you are going to talk about aqueductal stenosis, so we prefer going for these things like external ventricular drain or VP shunting. We'll talk about it later when we are going to talk about neurosurgery. So that's all about your brain injury. If you have any doubts, you can post it in the chat section. I can just cover it up later on. So now, whenever you are dealing with a thoracic trauma, so I told you there are few instances wherein you should suspect a thoracic trauma. Any RTA, suspect a thoracic trauma. Fall from height, because of the transmitted pressure, there can be a thoracic trauma, a spine fracture associated with it, and there is going to be formation of a hemothorax. So whenever a patient is going to come to you with a fall from height or RTA, always you are going to suspect thoracic trauma. So what are the 6 life-threatening emergency chest injuries which you should intervene? That is the airway obstruction, tension pneumothorax or open pneumothorax, massive hemothorax, flail chest and cardiac tamponade. So whenever these patients are going to come to you in the casualty, make sure that you are going to check all of these in the casualty before shifting the patient for investigations. Because many times what happens is, in the heavy casualty, you tend to miss out these things and then you are going to refer the patient. So what are the 6 things? Again, important: airway obstruction, which again, as we saw in the primary survey, we are going to check for control of hemorrhage, then airway, breathing, circulation. So whenever you are going to talk about it, airway obstruction is to be checked. Tension pneumothorax and open pneumothorax. So what are the differences between tension and open pneumothorax? So in tension pneumothorax, the main thing is the doctor has tension. So just remember, in tension pneumothorax, the doctor has tension. Now don't take the word seriously. What happens is, in tension pneumothorax, there is the tension in the pleural cavity. Tension in sense of the pressure. The pressure in the pleural cavity starts building and it is going to compress the vessels. It is going to cause hemodynamic compromise. It is going to give rise to raised JVP. It is going to push the trachea to the other side, and that is the reason the mediastinum is going to shift to the other side, and it is going to create the tension in the thoracic cavity, which is going to be the cause of tension for a doctor. Because if you are not going to relieve it in time, the tension pneumothorax may worsen and the patient may die because of obstructive shock. So in the shock, we talked about different shocks. So patient might die of obstructive shock. So tension pneumothorax. And then what is open pneumothorax? So open pneumothorax is nothing but aao jao ghar tumhara. So what is going to happen? The air is going to get into the pleural cavity while the patient is going to inspire, and it is going to go out when the patient is going to expire. So it is going to, so the air is there in the pleural cavity. It can anytime come in and go. So there is no tension on the organs of the thoracic cavity, and that is the reason it is called as open pneumothorax. So how to diagnose tension pneumothorax? So a pneumothorax with hemodynamic compromise. So any pneumothorax with hemodynamic compromise, it is going to be a tension pneumothorax. So many times you will see that even in tension pneumothorax, the trachea is not yet deviated, but fall of saturation, rise in the pulse rate or drop in the BP. So these are the 3 indications of doing an emergency intervention to the patient. So any pneumothorax to the patient, straight away put ICD. If you are suspicious of hemothorax, you are going to put ICD. Flail chest, what is flail chest? We are going to talk about it as we are going to progress. So what is tension pneumothorax? So air enters the pleural space but cannot exit. So it is going to cause compression on the mediastinum, which is going to be life-threatening. And it is always a clinical diagnosis. So even if you are going to put an ICD to the patient is going to succumb. Relatives might say that the doctor is the cause of the death of the patient, but you can justify it in the court of law that I was clinically looking to the patient, I thought that the patient has a tension pneumothorax and I have put the ICD. So always remember, a tension pneumothorax is a clinical diagnosis. Whenever you think that the patient has tension pneumothorax, you can straight away put ICD. Nobody is going to challenge you. So do not wait for chest X-ray. So absent breath sounds plus tracheal deviation plus jugulovenous distension, hypoxia, hypotension. So any of these characteristics, if they are going to be present, any of these things are going to be present along with a chest trauma or reduced breath sounds, do not wait for chest X-ray. Straight away put the ICD. So what do we do immediately? So immediately we are going to do a needle decompression. So old guidelines used to say that needle decompression is done in the second intercostal space. But now the new ATLS guidelines say that while doing it in the second intercostal space, you can damage the mediastinal structures. Because the mediastinum is shifted to the other side, so there is high chances of mediastinal damage. So the new guidelines say that even you are doing a needle thoracocentesis, do it in triangle of safety. So what is triangle of safety? If anybody can put it in the comment section, I'll be more than happy, or I'm going to tell you at the end. So what is pneumothorax? So it is a sucking chest wound. So the air is coming in, air is flowing out, air is coming in, air is flowing out. Aao jao ghar tumhara. We talked about it yesterday that we are going to do a three-way compression bandage. So what we are going to do a three-way dressing. So how we are going to do? Cover the wound with three sides and let the flap be hanging. So the air will go out but not come in. And when you are going to do this? When you are going to do this after putting an ICD. So always you are going to do the dressing after putting the ICD. So first put ICD and then cover the wound. And when is the pneumothorax going to be? That is about the external wound. But when the pneumothorax is going to be caused because of tracheobronchial injury or lung injury, the thing is that whenever the diameter of the chest wall defect or the defect in the tracheobronchial tree is more than 2/3 the diameter of the trachea, so that is the time when patient is going to develop a pneumothorax. So this is an important MCQ point of thing, that whenever, that is because of physics. So whenever there is going to be a rent in the chest wall or in the tracheobronchial tree which is more than the 2/3, or the total area of that rent should be more than 2/3 time the diameter of the trachea, then only the patient will develop a pneumothorax, or it is not going to be there. So it is an audible sucking wound or it might be a visible wound. So insert the chest drain first. So as I said, always the chest drain first, then seal the wound with three-sided occlusive dressing. That is also called as the Asherman seal. So he was the scientist who actually discovered that three-way valve. So it is the Asherman seal, and never seal without the drain in situ. So always remember this. This line is given in the Bailey and Love. So always make sure that you don't do it before putting an ICD. What is massive hemothorax? So massive hemothorax is when the patient is having more than 1500 cc of the blood in the pleural space. But I am going to tell you one of the important things. What happens is when a patient is going to come to you in the casualty, you put the stethoscope and auscultate. So a pneumothorax will naturally, the air is going to cause, the air in the pleural cavity will give an absent breath sounds. But in hemothorax, what happens is you are checking the patient in the supine position. So this is the chest cavity of the patient. The patient is having massive hemothorax. What I'm telling is the patient is having a massive hemothorax, and that hemothorax is lying in the base of the lungs, and the lungs are actually floating. So the lung is actually floating on the massive hemothorax. So if you are going to auscultate the lung, you might not find that the patient's air entry is reduced. So you can find that the air entry might be normal. So that is the time when you should think that even the air entry is normal, but the patient is having hemodynamic compromise, the patient is having history of chest trauma, might be the chest compression test is positive. So that is the time when you are going to think that, oh, this patient might have a hemothorax, it's not pneumothorax, put an ICD, you might find blood. So you need to have that clinical judgment. So there is dullness in the percussion. So the first point given in the Bailey is percussion. They did not give the auscultation sign. There is hemodynamic instability, and auscultation from the front may be normal because the lung is going to float on the blood. Exact opposite on the pneumothorax. The pneumothorax, the air is going to come above the lung. So the air is going to come above the lung, and as a result, the pneumothorax is going to be easily picked up on the auscultation. So always remember that hemothorax is percussed and pneumothorax is auscultated. So always put the drain in the triangle of safety. What is the boundary of triangle of safety? I have still not got an answer. So I have a diagram later on. I have also forgot it. So let's see if I can recall it by the time I'm going to show you the diagram. So what is an indication for emergency thoracotomy? So what is an indication for emergency thoracotomy? Always remember, if the blood is more than 1500 cc, or after inserting the ICD, if there is blood loss of more than 1500 cc, or 200 ml for consecutively 2 hours or consecutively 3 hours. So it means that the patient is having massive hemothorax which is not yet controlled. So take the patient to the OT. And many people think that, let's consider that you are going to put an ICD to the patient. This is the pleural cavity. You have put the ICD to the patient. It is connected to the underwater seal bag. So what will I do? I am going to clamp this ICD. So if I am going to clamp the ICD, there will be pressure built up in the pleural cavity and the blood will naturally stop. The same mechanism which is going to be applied to the retroperitoneal hematoma. So what happens in the retroperitoneal hematoma? The blood gets collected between the posterior abdominal wall and the peritoneum, and it is going to compress itself, and it is going to cause the tamponading effect, and that tamponading effect is going to seal off any problem in the retroperitoneum. So they say that don't explore retroperitoneal trauma unnecessarily. But this phenomena does not work in the chest wall cavity, and that is the reason you should never clamp an ICD. So clamping an ICD is a really bad idea. So if a patient's blood loss is still happening, take him to the OT, and do an emergency thoracotomy. So what are the thoracotomy incisions? We'll talk it in the CVTS section. So emergency thoracotomy, you can do a pericardiotomy for hemostasis and no pericardiocentesis in we went down. So we'll talk about pericardial tamponade now. So when the patient is having a pericardial tamponade, the patient is going to have what is called as a Beck's triad. So what is Beck's triad? Beck's triad is muffled heart sounds, raised JVP, and hypotension. So as much as 50 ml of blood is more than enough for causing a pericardial tamponade. For lungs to actually cause a hemodynamic compromise, minimum blood is 500 ml. And 300 ml of blood is required in the pleural cavity to actually cause costophrenic angle blunting. But 50 cc of blood is enough in the cases of pericardial tamponade to cause obstructive shock to the patient. So it is Beck's triad, JVP, hypotension, muffled heart sounds, and there is a Kusumal sign. So whenever the patient is going to breathe in, normally the pulse pressure, whenever the person breathes in, the thoracic cavity is going to accumulate more blood, and as a result, the blood, the blood from the right heart does not go much into the lungs. So that is the reason there is the pulse pressure difference when the patient breathes in. So that Kusumal sign, the absence of raise in the pulse pressure or more rise in the pulse pressure than 10 millimeter of mercury, that is called as a Kusumal sign. And what is the bedside investigation to be done? It is always going to be a 2D echo. So whenever you are suspecting a cardiac tamponade, there is no role of doing pericardiocentesis. There is no role for doing a pericardiocentesis. Only pericardiocentesis is indicated for the patient to take him to the OT. So pericardiocentesis is only done for the patient to stabilize and take him to the OT. The obstructive shock is relieved, but there is no role of doing a pericardiocentesis for therapeutic procedure. You need a pericardiotomy. So whenever you are managing a trauma center, make sure that CVTS surgeon is always there on the call. So pericardiocentesis might be done in penetrating cardiac tamponade just for the patient to be taken into the OT. So what is the flail chest? So what is flail chest? We talked about flail chest, about the deadly 6 obstructions. So we are talking about them itself. So what is flail chest? So if the 3 consecutive ribs are fractured at more than 2 places, so what is going to happen? So whenever, let's consider this as a thoracic cavity, first rib, second rib, third rib, fourth rib, fifth rib. So what is going to happen? This part is fractured. So more than 3 ribs, more than 2 fractures. So if this whole segment is going to be fractured as a whole, what is going to happen is it is going to oscillate on the own. So whenever the chest wall expands, that this section is going to stay at the place, and hence you can see that section is going paradoxically inward. So whenever a patient with chest trauma is going to come to you and you are seeing that during inspiration the part of the chest wall is going inside, that means that the segment is a flail segment. And how do you manage a flail segment? So how are you going to manage a flail segment? So first is adequate analgesia, because rib fractures are extremely painful. Go for physiotherapy and O2. If the patient is maintaining well on the room air with moderate amount of pain, you don't need to intubate. But if the patient is not maintaining on the room air, then that is the time you should put invasive ventilation. And still if the patient is not recovering, then you should go for surgical fixation. So surgical fixation is the last line when it comes to managing the flail chest. Initially adequate analgesia, again we checked analgesia. How do you put? You can put an epidural catheter. A thoracic epidural putting to the patient will substantially reduce the pain of the patient, and it will actually help the patient to recover fast. And last one is the airway obstruction. So whenever there is going to be a foreign body in the larynx, as you know that the most narrowest portion of the larynx is going to be the post-cricoid region or near the cricoid area. So if there is going to be a problem with the cricoid cartilage and emergency you cannot secure the airway, the patient is going to present off with the stridor and accessory muscle use. The patient is going to have that air hunger. So what are you going to do? Try to clear it with suction. But if the patient is not maintaining, then that is the time you are going to go for a cricothyrotomy or a tracheostomy. So cricothyrotomy is nothing but, so this is the thyroid cartilage, this is the thyroid cartilage. Below that you are going to have the cricoid cartilage. And then below that you are going to have the tracheal rings. So this is the trachea. So when you are going to make an incision between the cricoid cartilage and the thyroid cartilage, this is going to be called as cricothyroidotomy, and the incision is always horizontal. So this question is asked typically in the surgery exams, that how are you going to make an incision in the cricothyroid area. So it is always a transverse incision, and when you are doing a tracheostomy, it is always done below the first tracheal ring, and that incision is always made vertically in emergency. So vertical incision or a U-shaped incision is made, but never a transverse incision when you are doing a tracheostomy. So you should know about it. So other important thoracic injuries. So this is nothing but this is tension pneumothorax. You can see that the mediastinum, this is the airway which is shifted to the right side. Whole mediastinum is shifted to the right side, and here you can see in the left side of the lungs you can have a massive pneumothorax. Yes, so I can see lateral border of pectoralis major, anterior border of latissimus dorsi, and the fifth intercostal space. Nice. Okay, so flail chest came in UPSC CMS. Nice. Exam मैंने दी नहीं है. I'm not sure about it. So rightly as you said, this is the triangle of safety, and always remember while putting the ICD, put it in proper 45 degrees. Proper 45 degrees is the place where you are going to actually put the ICD. So this is going to be, yes, the anterior border is going to be the pectoralis major, posteriorly edge of latissimus dorsi muscle, and inferiorly the fifth rib. So the ideal ICD should enter the skin from the fifth intercostal space, and ICD should go diagonally upwards, and it should enter the pleural cavity from the fourth intercostal space. So this is something which not much books mention. Why? Because after you are going to remove the ICD, if the defect is going to be in the same plane, the later on there are high chances of again patient developing a pneumothorax. So whenever you put the ICD, either you should put, while putting from the fifth intercostal space, if the patient has hemothorax, so if the patient is going to have hemothorax, put the ICD in the downward direction. So put the ICD in the downward direction. So one intercostal space below, that is from the sixth intercostal space inside the pleura, or the patient, if the patient you are trying to put it for a pneumothorax, put it pointing upwards, and that is going to be in the fourth intercostal space. So upwards in pneumothorax. So these are few tricks, clinical tricks which you should be knowing. So always remember, whenever a patient of chest trauma is going to come to you, you put an ICD by looking clinically, and now you are going to do HRCT for the patient. So HRCT. So when you are going to do an HRCT for the patient, you will find out what are the complications the patient is having. So one thing which the patient might have is the pulmonary contusion. So whenever a patient has a pulmonary contusion, the X-ray is normal. Always remember, the X-ray is going to portray the lung pathology which is 24 hours prior. Why? Because the X-ray, the changes to appear on the X-ray, whenever there is going to be some consolidation, there is going to be inflammation, then the macrophages are going to come, then there are going to be laying of collagen or whatever the calcium, and the 24 hours are required for actual X-ray to pick up any change. So X-ray is going to be normal in cases of pulmonary contusion, hence you are going to do HRCT, and the patients who are going to have that pulmonary contusion, if you are going to overload the patient with the fluids, the patient cannot tolerate the overload. So you might see that patients of pulmonary contusion, after resuscitating for 2 to 3 days, the patient develops sudden onset pneumonia, and patient goes on ventilator-associated pneumonia because of going on invasive ventilation. So it is not the ventilator-associated pneumonia, it is the wrong part of your own management, that you manage the patient with excessive fluids. So any pulmonary contusion, give fluids wisely. So fluid restriction, analgesia, physiotherapy, and ventilatory support. Avoid crystalloid overload. Literal words from Bailey and Love. A thoracic aortic disruption. So whenever there is going to be aortic disruption, it is typically seen with the deceleration injury. So when the patient is suddenly decelerating while traveling from a bus, or while traveling from a car, or while traveling from the bike, so whenever this is going to happen, it is because the first and the second rib and the clavicle, or the because of that, the patient's, the ligamentum arteriosum which is attached on the near the arteries, pulmonary arteries and aorta, because of that disruption, there might be an aortic disruption, and associated with that, you can also find out first and second rib fractures or clavicular fractures. So there might be a widened mediastinum seen on the X-ray, but it is rarely the cause for hypotension, because the aortic disruption might form aortic dissection. So always make sure that whenever the patient is having a deceleration injury and widened mediastinum, suspect thoracic artery. And what you are going to do, again a CT scan is to be done. And if a patient is going to have a disruption, you are always going to call an interventional radiologist to do a TVAR. So what is TVAR? It is endovascular aortic repair. So he is going to insert a stent in the aorta, and then that disruption part is going to be bypassed because of the stent. And these patients, because whenever there is going to be ruptured aorta, these patients are not going to reach to your hospital. So when the disruption is still not ruptured, then you are going to plan for putting a stent to the patient. In the case of tracheobronchial injury, you are going to suspect a tracheobronchial injury when the patient is going to have subcutaneous emphysema. So whenever you are going to palpate the chest wall of the patient or the neck of the patient, because of the tracheal bronchial injury, the air leaks in the subcutaneous space, and the patient is going to have subcutaneous emphysema and persistent air leak after drainage. So lung is not expanding, and it might be associated again with the deceleration injury. So single lung intubation is required. So when the patient is having right-sided tracheobronchial injury, if repair is not possible at that time, you can do a single lung ventilation and then do a bronchoscopy or surgical repair. So whenever there is a tracheobronchial injury, you are going to make sure. How are you going to suspect a tracheobronchial injury? How you are going to suspect? So whenever a patient is going to have a tracheobronchial injury, when you are going to put an ICD, in cases of simple or tension pneumothorax, the air gush is going to be there. Air gush is going to come out. But even after 24 hours, the air bubbles are coming. So whenever the air bubbles are coming constantly in an ICD, the first thing which you should think about is the ICD which is going intraparenchymal. So ICD might be entering the lungs, and that is the reason the air bubbles are coming. So if it is happening like that, we are going to withdraw the ICD. But even after withdrawing the ICD, the air bubbles are not stopped. Then you should suspect a bronchopleural fistula. So in cases of bronchopleural fistula, if the fistula is small, a small fistula might be managed endoscopically. But a large fistula, you should go for OT. A CVTS surgeon comes and is going to take the sutures on the ruptured part of the bronchus. So you should know these things when you are managing a patient of ICD in wards. Whenever the ICD is having air bubbling for more than 24 hours, it suspects that the patient might have a bronchopleural fistula. Blunt myocardial injury, the most common presentation of blunt myocardial injury is going to be arrhythmias. So you should always suspect that, and when the patient is going to have sternal fracture, you should check that. ECG monitoring, troponin and echocardiography, and treat arrhythmia. It does not need any type of surgery. Diaphragmatic injury. So always remember, I'll tell you a case. A patient had come to us in the casualty. The patient had severe abdominal pain, but patient was hemodynamically stable. So when we are going to talk about the abdominal trauma, I am going to tell you that a hemodynamically stable patient of abdomen undergoes a CT scan. So patient was taken for a CT scan. CT scan was absolutely normal, and then the patient was kept in the ward for maybe 2 or 3 days. But after 3 days, the patient started developing features of obstruction and dyspnea. So that was the time when we repeated the X-ray of the patient, and we found out that the patient had a diaphragmatic rupture. So diaphragmatic rupture is even missed out on a CT scan. So the two organs which are always missed out on a CT scan, one is diaphragm, and the second which is the bowel or mesentery. So these two things can easily be missed out on a CT scan when you are going to check a patient of your abdominal trauma. Why? Because the CT scan has a thin slice. So even if the thin slice is going to be there, a diaphragm is not even 2 mm or 3 mm in thickness. So because of that, the CT scan slice can easily miss out the diaphragm, and the diaphragmatic injuries can go unnoticed because diaphragm is placed transversely, and the CT cuts are also taken in the transverse fashion. So a diaphragmatic injury can always be missed out on a CT scan. So make sure that if the patient is deteriorating, either there might be some complication to the bowel or there might be some complication to the diaphragm. So always suspect it in the mind that when you are conserving a hemoperitoneum or a chest trauma patient, these two things are easily missed out on your CT scan. So diaphragmatic injury often missed on the CT scan, and it should be repaired always with an abdominal approach. And why abdominal approach? Because In abdomen, there might be injury associated spleen, liver, stomach, esophagus. So always you are going to approach the diaphragmatic injuries through the abdomen. And laparotomy and repair, if found laparoscopically, you can also do for a laparoscopic repair. Later on, the patient might develop, if the patient goes unnoticed, later on he might develop a diaphragmatic eventration or diaphragmatic hernia. And one question which can come to you in the exams is, what are the indications of emergency room thoracotomy? So you might have seen that the movie of Attacks of 2611. So how was he there in the casualty? So he used to open the, so we have seen one incident that he opened the patient in the casualty there and then, and he started giving the pumping action to the heart. Everyone in the casualty was like, don't do such morbid procedure for the patient, but he opened up the chest cavity and started giving direct cardiac massage. So when do you do a direct cardiac massage? So always remember, any penetrating trauma, what I am saying, any penetrating trauma and an intubated patient with cardiac activity but no output. So whenever a patient is having a gunshot injury, a penetrating injury to the chest wall, patient is having cardiac activity on ECG, but there is no actual blood pressure monitored or carotid arteries are not felt. So that is not the time to start the CPCR. You should do an emergency room thoracotomy. So whenever you are going to do an emergency room thoracotomy, the first thing you are going to do is you are going to cross clamp the aorta. So this is the aorta of the patient. The aorta is going, and the three branches, left common carotid, left subclavian, and right brachiocephalic trunk. So these three branches are important to maintain blood supply of all the vital organs, that is the brain, lungs, and the heart. So you can cross clamp the aorta after the origination of the left subclavian artery, and you can give a direct cardiac massage. So direct cardiac massage is given in patients of penetrating trauma with cardiac activity without blood pressure or without pulse. So you are going to always do that, and that is going to have better outcomes. Another thing is when the patient suddenly collapses in front of you and you know that the patient is having blunt trauma to the chest, that might be an indication, but again the results are controversial. So the morbidity caused to the patient during that time is not justified. So the only indication which is given in standard textbooks is when the patient has penetrating trauma to the chest and patient is having cardiac activity on ECG and no actual BP or pulse recordable. So always make sure that you know these indications. So open the pericardium, cross clamp the aorta, internal cardiac massage, repair the cardiac wound if there, not indicated for blunt chest trauma. So Bailey clearly states that there is no role of it in blunt chest trauma. So always remember that. So chest drain principles, again in 4th and 5th intercostal space, anterior axillary line, lateral border of pectoralis major, inferior border is axillary bearing the area of the skin and avoids neurovascular structure. So always remember you should go on the above the rib, not below the rib. So if you go below the rib, you are iatrogenically causing the intercostal vessel injury. So always go above the rib. Persistent lung non-expansion. So if even after putting an ICD, the lung is not expanding, it might be because the patient's the lung capacity is not that high. So in that sense, you can actually apply a suction to the ICD. So this is given in Bailey Love. I have not seen actually clinically using this much, but in Bailey Love it is given that you can apply a suction of -5 centimeter of water. And persistent collapse despite drainage, a second drain can also be put. So simultaneously you can put 2 ICDs on one chest side. It is still indicated. And antibiotics, there are no routine role of antibiotics. If the patient has a penetrating trauma, the only single dose of prophylactic antibiotic can be given. And again, as I said, no role for clamping the chest drain. Free drainage should be maintained all the times. And we saw the criteria for doing emergency thoracotomy. What you are going to do if the patient is having more than 1.5 liters of blood loss or more than 200 ml of blood loss per hour for 4 consecutive hours or 3 consecutive hours, you are going to take the patient for thoracotomy. So this is the mechanism of Flail segment. So this segment is going to pop out when the lung is going to go in, and when the lung is going to expand, this segment is going to go inside. Because this segment is running on its own, it has lost the connection with the other thoracic organs. So more than 2 fractures at more than 3 consecutive ribs is the definition of flail chest according to Bailey and Love. So I hope the chest trauma module is very much clear to you, and now we are going to go something which is called as the abdominal trauma. So if there are any doubts, you can post it. So does pulmonary contusions cause ARDS? So exactly, the pulmonary contusions are going to disrupt the membranes of the endothelium, and if you are going to give more amount of fluids, there is more pulmonary edema. So direct ARDS, no. But how is it going to cause an indirect ARDS? So more fluids. So because of the pulmonary vasculature is not maintained properly, it is going to cause pulmonary edema. And we know that pulmonary edema can easily be infected because whenever the patient breathes in, there are a lot of pathogens, especially when the patient is admitted in the hospital. So patient can develop a pneumonia, and that can cause ARDS. that can cause ARDS. So what is abdominal and pelvic trauma? So now we are going to talk about abdominal and pelvic trauma. So now talking about how to approach a patient of abdominal trauma. So firstly, remember, when a patient is going to come to you in the casualty, whenever the patient is going to come to you in the casualty, abdomen is going to be the last thing which is going to be seen by the patient. The patient will first look on his abrasions, the patient will look first at the head injury, facial trauma, his thoracic trauma because he is not able to breathe or problem in breathing, and last thing which the patient is going to complain is about the abdomen. So what is important is when you are going to palpate the patient of abdomen, if you are going to see any type of guarding, rigidity or tenderness. So what is tenderness, guarding and rigidity? So after palpation, the patient winces in pain. There is no reaction from the abdominal wall. There is only pain seen on the face of the patient. It is tenderness. When the patient is going to contract the muscles, then it is going to be guarding. So initially the guarding is voluntary. What is voluntary guarding? That whenever the patient feels pain, he will contract the muscles. How to minimize the voluntary guarding? Ask the patient to talk to you, talk with the patient, and then the voluntary guarding will subside. But even after talking to the patient, the muscles of the abdomen are contracting on your touch. It means that the patient is involuntary guarding. And what is rigidity? You touch or you don't touch the patient is still going to have the abdomen which is going to be tense or it is going to be rigid. So that is nothing but board-like rigidity. So these are the 3 steps of development. So tenderness, guarding and rigidity. So whenever an abdominal patient is going to come to you in the casualty, hemodynamically stable with abdominal signs, then you are going to suspect the patient. Then you are going to take the patient for a fast. So what is fast? So ideally in all the tertiary care casualties whenever the patient is going to come to you, you are going to put a probe on the abdominal cavity. So what is the probe? So as the fast says, so let's consider what is fast. Focus assessment, sonography for trauma. So what are the 4 things the fast is going to check? The first is the heart. It is going to check left and right. What we are going to check is the abdomen. So both lumbar regions. And this is going to be the pelvic cavity. So this ideally is nothing but fast. So this S of fast is going to check for heart, both the abdominal sides, and other is going to be pelvis. So these are the 4 structures which you are going to see. More detailing, these probes, the probe in the near the heart and the pubic are placed transversely, and the abdominal probes are placed vertically. So while doing the fast, you should know how to place the probe exactly. So in the in the epigastric region, place the probe horizontally. In the pelvis, place the probe horizontally, and in the abdominal flanks, you are going to place the probe horizontally. What is extended fast? So when you are going to cover the pleural cavities along with the abdominal cavity, so both the pleural cavities are going to be covered. So this is nothing but this is your extended fast. So whenever a patient comes to you in the casualty, ideally you are going to do extended fast of the patient. So focus assessment sonography for trauma. So what is important? So you can check the pericardium, you can check the hepatorenal pouch, splenorenal, pelvis and pleural spaces. Minimum of 100 ml of fluid is required to detect something in the fast. And pericardial fluid is tamponade unless otherwise proved, and 50 ml of pericardial tamponade is enough to cause obstructive shock. What is the problem? So if the radiologist is not available and you are going to do it and you are not very good at that, then that is the time when you should know that you might miss out on the findings. So what things you cannot see on the fast? Because of the bowel gas, you cannot see the retroperitoneum. So kidneys can be missed, major vessels can be missed, and hollow viscous perforation can be missed. Unless there is gross air in the peritoneal cavity, a small perforation can be easily missed on the basis of fast, because the bowel gas is going to obscure. Whenever you are going to go for USG at some place electively, the sonologist is going to tell you to be NBM for 6 hours. Because of that, the bowel is going to be emptied and the bowel gas is not going to hinder the findings. So whenever there is going to be a bowel gas, there is going to be hamperment of the findings, and hence in fast you can miss out the findings easily. So if a good radiologist is there with you, easily you can pick up the findings. But if the radiologist is not there and you don't know the things properly, then there are high chances of you missing the things. सर फास्ट तो पहले नहीं था, पहले क्या ट्रॉमा नहीं आता था? Yes, there used to be trauma, and that time the people used to do DPL, what is called as a diagnostic peritoneal lavage. Now it is a matter only of questions, because it is not coming anywhere in clinical practice these days, because everywhere a sonography and CT scans are now available. In all, even government setups, these things are available. So what is diagnostic peritoneal lavage? So 1 liter of warm saline, or few books say 1 liter of warm RL is infused via periumbilical catheter. So umbilicus at the level of infraumbilical region, this is the patient's abdomen, this is umbilicus. So at the infraumbilical region at 45 degrees, a needle was inserted in the abdomen cavity, and 1 liter, firstly you aspirate it. If there is frank blood in the abdominal cavity, it means that the patient is going to have massive hemothorax. So when this is going to be happening, when the patient is going to have a massive hemoperitoneum, you can straight away take the patient for exploration. But if the aspirate is negative, then you are going to instill 1 liter of normal saline or RL, so whichever is available, but it should be warm, because cold saline again can cause reactionary ileus of the patient, might cause complications. So after infusing 1 liter, and then again you are going to aspirate, or you can just remove the catheter and you can place the IV line in the saline bottle. So if the blood is going to come through that, if the saline is going to come, blood tinged saline is going to come, it means that the patient is going to have a positive fast. So frank blood return or RBC, so that time pathologist is to be disturbed. So whenever you are doing a diagnostic peritoneal lavage, that fluid is aspirated and sent to the pathologist. And if bile is present, or if you feel that any bacteria are seen, or 500, so firstly, if all these things are present, it means that there might be some hollow viscous injury, or there might be some hemoperitoneum, and if the patient was unstable, it was explored based on the DPL. But nowadays a diagnostic peritoneal lavage is out of question. We are not doing it. It is invasive, it misses retroperitoneal space, but it is the last source. It is now largely replaced by CT scan. So nowadays diagnostic peritoneal lavage is not used, but you should know that how diagnostic peritoneal lavage was initially being used. So they used to infuse 1 liter saline, few books say 500 ml RL first, and again 500 ml later if no aspirate, but 1 liter is the standard. So insert it from the infraumbilical port at 45 degrees, wait for some time, and then you are going to aspirate. If aspirate is negative, connect it to the bottle, keep it down. If it is blood tinged, it is positive. If it is bile tinged, it is perforation. If it looks pus, it means there is an abscess, so you can explore the patient. So initially it was used, nowadays it is not used. What is the gold standard? CECT abdomen. But when? If the patient is stable. So if the patient is stable, then only CECT abdomen. So when the patient is stable, then only you are going to go for CECT abdomen. So WBCT with IV contrast is the investigation of choice, and solid organ injury can be seen. Solid organ injury can be seen on a CT scan because of arterial blush. So if an arterial blush is going to be present, it indicates an arterial bleeding. So if an artery is bleeding, what is my next step of management? So should I go for a laparotomy? No. Nowadays in tertiary care centers, you can go for embolization. So if a patient is stable, again, when are we going to do a CCT? If the patient is stable, and we are going to find an arterial bleeding, it is a stable patient. Take him to the interventional radiology department and do an embolization. But if a patient is unstable, CT has no role. A positive fast plus unstable patient, straight away take for laparotomy. What is the problem? It requires radiation, it requires hemodynamically stable patient, and misses, as I said in previous chapter, it can easily miss small bowel and diaphragmatic injuries. So very much important for you to know that whenever you are going to suspect a patient of hemoperitoneum, whenever the patient is going to have a CT scan, always make sure that you are always checking diaphragm and small bowel at regular intervals. So how to check small bowel? Obviously bowel sounds. If the patient is going to have prolonged ileus, it means that there is some problem. Abdomen should settle down. If the patient has guarding and rigidity at the time of presentation, you did a CT scan, you found out it is a hemoperitoneum, it might be a liver or spleen injury, but later on the patient's guarding and rigidity should subside. If it is not subsiding, the tachycardia is not settling even after resuscitation, if the HB is normal, the hematocrit is normal, still the tachycardia is present, fever spikes are there, it means that there is something which is missed out, which is bowel. It is something which is missed out, it is bowel. Oh, hi Gaurav. Thank you. I'm not any god of surgery, but great, you have joined the lecture. I'm so happy to see you. So that's important. What is about the X-ray? So X-ray is only going to tell us about your gas under diaphragm. So any hollow viscous perforation can be seen in the X-ray. But another important thing is X-ray when you are going to clip the wound. So whenever you are going to see a gunshot, whenever the gunshot entry wound is present but exit wound is not there, the gun is inside. So whenever you are going to see a gunshot injury, you can place a clip on the external wound and you can check the X-ray. So anterior X-ray and lateral X-ray. So you can actually check the angle and trajectory of how the gunshot has traveled. So what is the role of X-ray in abdominal trauma? Only to diagnose the hollow viscous perforation. And second thing is to check the trajectory. To check the trajectory of gunshot. So abdomen is the Pandora's box. So injuries can easily be missed. So E-FAST is a screening tool. E-FAST is not a diagnostic tool. And always remember, any hemodynamically patient unstable with positive FAST should undergo an immediate laparotomy. So a basic mechanism of how to approach a patient of abdominal trauma. So whenever an abdominal trauma is patient to come to you, so whenever abdominal trauma patient is going to come to you, first you are going to check out how you are going to suspect abdominal trauma. So again, as I said, tenderness, guarding, or rigidity. So if it is there and patient is giving complaints of abdominal trauma, first you are going to check the patient if stable or not. Stable or unstable. So if the patient is unstable, the first thing, irrespective to stability, you are going to pass if FAST is feasible or not. So FAST can be done bedside. So FAST is to be done fast. So E-FAST is what you are going to check for. If E-FAST is positive and patient is unstable, go for a laparotomy. But E-FAST might be positive or negative, but patient is stable, go for a CT scan. But when the patient is having signs of guarding, rigidity, or tenderness, then only. If the patient is saying that I had an abdominal trauma, patient is walking to you in the casualty, E-FAST is negative, then that is the time you can conserve the patient. Because many times you might find a patient who comes to you, I just got a handlebar injury to my abdomen, I am having some abdominal pain. So it's okay. Don't expose him to radiation unnecessarily. An X-ray and a USG with a patient being very hemodynamically stable is totally fine. You should not go for a CT scan. But an unstable patient or any abdominal signs, hard signs of abdominal trauma, tenderness, guarding, rigidity, bruises on the abdomen, there might be some abdominal distension, persistent vomiting. So any abdominal signs with history of abdominal trauma in a stable patient should undergo a CT scan. Or if FAST is positive, there are no signs of abdominal trauma, but FAST is positive. FAST is going to tell you that there is going to be mild hemoperitoneum, but there are no signs of abdominal trauma. Then also you are going to go for a CT scan, but in a stable patient. So these are the basic approach you should know. So specific organs. Now there is going to be AST grading. So what happens is there are grades of injuries. So there is going to be grade 1 to grade 5 splenic injury, grade 1 to grade 5 liver injury, grade 1 to grade 4, grade 5 kidney injuries. Sir, if I am going to teach you everything, then again, what is the use of attending lectures? That is available on your chat GPT also. So you can learn it from your AI. So what is my role here? I am going to tell you how you are going to manage a patient broadly. So whenever a splenic trauma patient comes to you, what I am saying is whenever a splenic trauma, a patient is come to you, you did a CT scan, you found out that the patient has a splenic trauma. It might be grade 1 to grade 5 according to the latest AST guidelines, according to the latest trauma protocol. Any splenic injury with stable hemodynamics, you are going to conserve. So that is the new protocol. Initially they used to tell, the old protocol was grade 1, grade 2 conserve, grade 3 if stable conserve, grade 3 if patient is unstable operate, grade 4, grade 5 operate. So what happens, there are three conditions. One is contusion, one is splenic laceration, one is the subcapsular hematoma, and the fourth thing is the vascular injury. So taking all these things into component, initially if the patient had grade 1 or grade 2, it used to go under conserve. If grade 4 and grade 5 operate, and grade 3 was decided on the basis of stability. But now they say that check the patient clinically. If the patient is improving on your stable, if the initial presentation is stable, if the patient is not having tachycardia, hypotension, if the patient's abdomen is settling down within 6 hours or 8 hours after resuscitation, you need not do anything. If there is going to be an arterial blush, anywhere you come across a CT scan with arterial blush, go for embolization. So those are the MCQs straight away, and that is actually what is done in the ideal clinical practice at tertiary care hospital. So if you are practicing somewhere in the rural areas and you don't have anything, it is arterial bleeding, obviously you should go for a laparotomy. But if you have the ability of doing an interventional procedure, you should go for an interventional radiology guided embolization. So splenic trauma, simple what I told, grade 1 to grade 3 stable, close monitoring of the patient is required. So what do you monitor in these patients? So one thing is you are going to check for HB. The another thing is you are going to check for vitals, and other is going to be the AG monitoring. So what is AG? It is the abdominal girth. So one more clinical hint about abdominal girth. One time I went to discuss a case with pediatric surgeon. So while talking with the pediatric surgeon, there was a baby admitted in my ward who was having hemoperitoneum. The baby was absolutely stable. Baby was absolutely stable. But what the only thing complaint was, his HB was normal. He was not tachycardic. He was non-hypotensive. His abdomen was comparatively getting softer, but the AG was increasing. So the only thing which the baby was suffering was an increase in AG. And so that was the time I went and discussed the case with pediatric surgeon. So he gave me an excellent, beautiful explanation of why the AG is not a very good indicator of what's going on in the abdomen. Because of the blood in the peritoneal cavity, the peritoneum is irritated. And when the peritoneum is irritated, the bowel is going to go into the ileus. So when the bowel is in ileus, naturally the bowel contents are going to accumulate and the abdomen is going to distend. So whenever you are checking for a patient for conservative management of hemoperitoneum, always you should check all the parameters: hemoglobin, hematocrit, pulse, blood pressure, his saturation, his tachypnea, and his AG. So AG comes at the last. So even if AG is increasing but patient is stable, you need not worry. You need not worry. So that is a thing which a pediatric surgeon taught me, and it was very important in my lifetime, so you should know about it. So liver, most commonly injured organ. So the most common blunt, again MCQs, most common wale things. So most common blunt trauma injury is spleen. Most common penetrating injury to abdomen is liver. So again, seat belt injury, it is going to be mesentery or duodenum. Mesentery or duodenum. And sudden forward fall, it is going to be aortic disruption. So it is going to be aortic disruption. So most common injury, again penetrating trauma. So again, liver is to be managed conservatively unless patient is unstable. Again, important thing, if a patient is stable, any grade 1, 2, 3, 4, 5, managed conservatively. Only if the patient is going to have arterial blush, again refer him for a CT scan. Now, another important thing is when the patient is unstable, what are you going to do? So for spleen, you can do a splenectomy, but for liver, you cannot do a hepatectomy. It's not that easy, and after hepatectomy, how is going to patient survive? So whenever the patient has bleeding inside the liver, the first thing which you can do so let's consider what are you going to do when you're going to explore the patient of liver and you are going to find out that the patient is having massive liver bleed. So the first thing you are going to do to a patient when you are going to open and you are going to see the bleeding is going to do a Pringles. So what is Pringles? This is the liver, this is the portal triad. So this is the portal triad. So this is the portal vein, hepatic artery. So whenever you are going to actually see that the patient is bleeding, you are going to clamp this portal triad. So how much time you can clamp? You can ideally clamp for 20 minutes. So 20 minutes clamping is more than enough. So after clamping, the bleeding stops. Easy, the injury is in the portal vein or might be in the hepatic artery. So if the injury is with the hepatic artery, you can straight away ligate the hepatic artery in trauma. I know that hepatic artery ligation might lead to ischemia and further necrosis, etc., etc. But for trauma, we are saving the patient's life, so hepatic artery is justified. Portal vein, you cannot ligate the portal vein. If you ligate the portal vein, the liver is going to go for a toss because 80% supply from portal vein and 20% from the hepatic artery. So hepatic artery can be ligated in cases of trauma. Never ligate hepatic artery in cases of elective surgeries, because ligating hepatic artery is going to cause cholestasis and intrahepatic biliary damage, because all the biliary tree gets supplied from the hepatic artery and not from the portal vein. So liver might not have problems, but patient might develop intrahepatic strictures later on. So again, we are going to talk about it in the liver chapter, but hepatic artery can be ligated in cases of emergency and trauma. Never you are going to ligate the portal vein. But now the bleeding is not stopping even after doing a Pringles. So what might be the cause? So the cause is it might be leading from something big which is there behind the liver. It is nothing but IVC. So the bleeding might be coming from IVC or it might be coming from the hepatic veins. So what to do during this time? So this is the deadly condition, and if the bleeding is not stopping or there might be some laceration because of which the reverse flow from the vein is causing bleeding. So what is the first thing to be done? The first thing is reduce the CVP. So when the CVP is reduced, when the patient is going to be vasodilated, naturally the IVC flow is going to reduce, the blood is going to be pulled in the extremities, and because of reducing the CVP, less pressure on the hepatic veins and less bleeding. So first thing is reduce the CVP. When even after doing the Pringles, the bleeding is not stopping, reduce the CVP, and then you can actually plan for repairing of IVC. Again, you can plan for repairing of IVC. So first thing is you are going to do Pringles. Then the second thing you are going to do is you are going to pack the cavity with mops. Even if it is not happening, you can plug it with Foley's. And then you can come out. So what is the important phenomena? If the patient is hemodynamically stable, you know that the bleeding is from the IVC. Patient is hemodynamically stable, go and repair. If you know that patient is unstable, just pack the cavity with sponges, release the Pringles maneuver, let the bleeding stop, because after packing, any venous bleed is going to stop after packing. Any venous bleed, even an IVC bleed can stop itself after packing. The clot will form, organize, and bleeding will stop because it is a low pressure system. Never try to repair any vein in haste. An artery can be repaired easily, but repairing a vein is very cumbersome. So never touch any vein when you are in a hurry. So whenever a venous bleed is there, just pack it off and just come out. If the patient is unstable, then you are going to do damage control surgery. So what is damage control surgery? Right now, just stop the bleeding, take the patient to the ICU, wait, let the patient stabilize in the ICU, then again take the patient to the OT, and then you can suture the IVC. So you should understand that what is to be done when you are going to explore the patient of liver trauma. So whenever the patient is going to have a trauma, you are going to do the Pringles maneuver. And if it is not going to be stopping, then you should know that the bleeding is coming retrohepatic. That might be from the retrohepatic IVC, or the bleeding might be coming from the hepatic veins itself. So these are the things which you should know. Duodenum, again, as it is a part of small bowel, it might be easily missed. And problem is there is poor blood supply here in the duodenum, because we know that the foregut supplies to the first and second part of the duodenum, and the SMA is going to supply to the third and fourth part of the duodenum. So there is going to be an anastomosis and watershed area at the second part of the duodenum. So whenever there is going to be a vascular injury near duodenum, it is inevitably going to be fatal. So always it is a devastating complication, and it might also be associated with the pancreatic trauma. So whenever you are going to feel a steering wheel injury, always suspect that the patient might have a duodenal injury. Colon, as I said, rarely it gets damaged because of blunt trauma. Mostly the colon is always culprit of penetrating trauma. So I had a patient who had a stab injury. So I'm telling a real case. A patient had a stab injury 7 days ago. After a stab injury, normally what happens is, if nothing is coming out from that stab and you feel that the stab is so small that it might not have damaged anything, what are the protocols? You send the patient, if the patient is stable, a stab injury without any viscous protruding, or you know that the peritoneum might or might not be breached. So that is the time you refer the patient for a CT scan. So what did I say? A stab injury, no peritoneal breach seen clinically, and patient is stable. A CT scan was done, it was normal. Patient was sutured and sent home. 7 days later, patient went to the same hospital, but that time he had abdominal pain and distension. Then they repeated a CT scan, and there was a component of peritoneum. So what did I say? 7 days before, stab injury without peritoneal breach, stable patient, CT scan normal, patient was sutured and sent home. 7 days later, patient presented with pain in abdomen, and patient was having abdominal distension, tachycardia. Patient came to the hospital, they repeated a CT scan, and in the repeat CT scan, hemoperitoneum was found. And then patient was referred to our hospital. So after referring the hospital, we also repeated a CT scan, because being a medico-legal case, you always have to be safe, because you cannot rely on the outside reports. So yes, it confirmed hemoperitoneum. Patient was unstable. What I'm saying, a hemoperitoneum without any cause in an unstable patient, in a deteriorating patient, laparotomy is justified. So we explored the patient, and we found that there were 2 colonic rents. So 2 small colonic rents in the lateral wall of left colon. So what I'm trying to say is, a colon injury is always associated with penetrating type of trauma, and never it is associated with blunt type of trauma. And always, if it is a clean wound, you can just repair it. But if the patient is having contamination, just go for a functional stoma. So defunctioning stoma is placed, and later on let the wound heal, and then you are going to check for the patient. Any rectum examination, again, in any rectal wound should not be repaired in haste. always do a defunctioning sigmoidostomy and wash out. So just wash the wound, place the drain in the rectal region and do a defunctioning stoma. And in cases of bladder, always suspect a bladder fracture when you are going to, suspect a bladder perforation when it is associated with a pelvic fracture. So when it is pelvic fracture, so always remember, when it is pelvic fracture, we are going to talk about pelvic fractures, the bladder might have injury. And two types of bladder injury: intraperitoneal or extraperitoneal rupture. So extraperitoneal rupture, what happens is that rupture is going to increase in the size when the bladder is going to inflate. So after inflation, the rupture will increase, but after deflating the bladder, that small opening is going to close off on its own. So what do? You put 6 weeks of urethral catheterization for a patient of extraperitoneal bladder rupture. So in case of extraperitoneal bladder rupture, you are going to go for Foley's for 6 weeks. And in intraperitoneal rupture, that intraperitoneal leak of the urine can actually cause bowel edema and peritonitis. So intraperitoneal rupture is always repaired. So always remember that whenever you are going to do a CT scan in a pelvic trauma patient, make sure that the bladder is distended, because if the bladder is collapsed, because of the collapsed bladder, the small rent are always going to be missed out. Whenever you send the patient for getting a CT scan of the abdomen done in patients of abdominal trauma with pelvic fracture or with pelvic injury, always the radiologist is going to say that please distend the bladder. Either do it either do it from per urethral, or if you don't feel, let the patient wait for some time and then you are going to check for it. So that is about bladder rupture. So always, as I said, if CT scan is available, it is always good. But if CT scan is not available, you are going to instill 300 ml of contrast from the Foley's catheter and you are going to shoot an X-ray. So if the extravasation is going to be in the preperitoneal space, it means that it is extraperitoneal rupture. But if you can see the dye in the peritoneum near the bowel loops, then it means that it is intraperitoneal rupture and the laparotomy is indicated. But nowadays, barely anybody does this cystourethrogram. Normally, everybody is going to do what is called as a CECT with bladder inflation. And again, if it is extraperitoneal, just do drainage for 6 weeks. So I hope it is clear. So what is remaining is retroperitoneal trauma and pelvic fractures. So we are going to cover pelvic fractures and retroperitoneal trauma in the next week. So I'll give you a small break of Saturday and Sunday. Weekends hai, to enjoy kar lo. We have been studying together for almost like past 7 days starting from Sunday. So we'll take a break of Saturday and Sunday. We'll meet on Monday at the same time. I'll post the link on the group as usual. And hope you don't have any doubts. If you have any, you can ping me on the WhatsApp. I'm always available for solving any doubts of yours. So till then, take care, bye bye and good night. Thank you for attending the lecture.